Hello, and welcome to the CAP Today webinar for Thursday, June the 2nd. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host and moderate a question and answer session after our formal presentation. Today's webinar is entitled Systemic Mastocytosis, Overview of Disease and Diagnosis for Pathologists. Our webinar today is a non-accredited promotional activity made possible by a sponsorship from Blueprint Medicines. We want to acknowledge Blueprint Medicines and thank them for their support and help in allowing us to bring you today's program. Our single speaker, and I'll say more about her in due course, is Dr. Sheeja Pullarkat, Professor of Pathology and Lab Medicine at UCLA Health in Los Angeles. But first, let me go through some housekeeping tips that I think may enhance your enjoyment. First, we often think that you should refresh your browser. It keeps things in optimal sync. You'll see in the lower right-hand corner of your computer screen, there's a toll-free number. We have live operators standing by throughout today's webinar to help you with any technical support issue that you may have, and you can dial 858-345-5916 for that. You'll see below the slides a box labeled Q&A. And you can also type in any questions about technical problems or difficulties that you're experiencing there. Again, live aid will come on immediately to help you resolve your problem. Of course, the Q&A box is really for your own comments and questions about today's content and presentation. As I said before, at the end of today's session, I'll lead a Q&A session with Dr. Pullarkat, and we look forward to hearing all your questions and your comments. You'll be able to see the full slides and audio of today's webinar in about a week. We'll post that at captodayonline.com, and many people enjoy reviewing and sharing the webinar content after the fact. You'll likely see some follow-up email from ourselves and from Blueprint Medicine, so I want to alert you to that. And finally, as always, it's important that I remind you that CAP Today does not endorse any product or service that may be mentioned in today's webinar. Any comments of mine, of course, are purely personal and not to be taken as policy of the CAP Today or the College of American Pathologists. And so now it's my great pleasure to really get the webinar underway by introducing our speaker. Dr. Sheeja Pullarkat did her residency in AP and CP pathology at USC. She followed that with a Hematopathology Fellowship also at USC, and then crossed town in 2006. She's the Professor of Pathology and Laboratory Medicine, and importantly, the Director of Hematopathology Fellowship Programs at UCLA Health. And so it's a great pleasure for me to introduce Dr. Pullarkat, and I'll ask her to begin her lecture now.
Thank you, Bob. Hello, everyone. Good morning and good afternoon to all of you based on your respective locations. During today's presentation, I will review systemic mastocytosis and provide a disease overview and discuss the diagnostic workup of SM. Before I start, let me just point some program disclosures. This is a non-accredited promotional activity that is sponsored by Blueprint Medicines, and I'm speaking on behalf of Blueprint Medicines. And this program is intended to provide general information and not medical advice for any particular patient. Note that all materials that are presented today are property of Blueprint Medicines and should not be recorded, photographed, copied, or reproduced. With that, let me begin. So the program outline for today is, first, I will discuss systemic mastocytosis and provide you with an overview, followed by systemic mastocytosis SM evaluation and diagnostic workup. And then we'll talk about some technical challenges and how we can optimize testing in our labs And then in the end, we will close today's presentation by summarizing the key points and conclusions. So SM is a clonal mast cell neoplasm that is driven by the KIT mutation. Particularly in 95% of cases, it is driven by the KIT D816V mutation. And patients with SM, they present with a heterogeneous, wide variety of symptoms based on the disease, on the system or the organ that is involved by these neoplastic mast cells. And this can include the bone marrow, GI tract, skin, liver, and the spleen. A point to note here is that there is an urgent need to diagnose SM, especially advanced SM, since it is associated with a reduced overall survival due to organ damage. So SM is classified as a myeloid neoplasms by WHO, and under the myeloid neoplasms falls mastocytosis, myeloproliferative neoplasms or MPN, myeloid and lymphoid neoplasms with eosinophilia, MDS-MPN that includes the CMML, MDS, and myeloid neoplasms with germline predisposition. Mastocytosis is further subdivided into systemic mastocytosis, which is what we will be talking about today. And in addition, note that you also have the cutaneous mastocytosis with skin-only involvement and mast cell sarcoma. So systemic mastocytosis is further subdivided into the non-advanced SM, which includes indolent SM or the ISM and the smoldering SM or the SSM, and the advanced SM, which includes aggressive systemic mastocytosis, mast cell leukemia, and SM with associated hematologic neoplasm. The prevalence of systemic mastocytosis is estimated at around 1 per 10,000 adults, and in the advanced SM, the patients with SM-AHN, it constitutes 70% of the diagnosis in advanced SM. So like I said, right, these patients, they can present with a wide variety of symptoms based on the organ involvement. So these patients can present to the allergy immunologist, present to the dermatologist because they have skin rash or other skin symptoms, endocrinology, gastroenterology, patients may have diarrhea, malabsorption, weight loss, hem-onc, patients are feeling fatigued, cytopenias. Therefore, it is noted that in these patients, to nail the diagnosis of SM, it takes a long time. And studies have shown that from the onset of symptoms to the diagnosis, in patients with advanced SM, it took around 3 years. And in patients with non-advanced SM, it took around 9 years to nail the diagnosis of SM from the time that the patient started presented with symptoms. So this delay in diagnosis is particularly notable given the fact that the median overall survival in patients with advanced systemic mastocytosis, it can range anywhere just from 2 months to 3.4 years. Therefore, again, the need to make a timely diagnosis. And studies have shown, this is a study that was published by the European Competence Network on Mastocytosis, and this included more than 1,600 patients, both with advanced SM as well as non-advanced SM, and it was shown that in these patients, the overall survival was lower than patients with cutaneous mastocytosis. So here, the take-home is that both non-advanced and advanced SM may be associated with a decreased overall survival. In addition, pathologists, we play a key role in facilitating an accurate diagnosis of SM. There was a study that was published on a retrospective analysis of 140 patients with advanced SM from the same German group, and it was shown that there was a misdiagnosis in close to 36% of patients with advanced SM. Out of these 36%, in 20% of these patients, the SM was completely overlooked in patients who actually had an SM with an associated hematologic neoplasm. So the SM part was completely overlooked. And in the rest of the 16% patient, what happened was that these patients were diagnosed with an indolent systemic mastocytosis because the signs and symptoms that would have categorized these patients as an advanced SM was completely overlooked. Therefore, it is important that whenever we see a patient with a myeloid neoplasm, it is very important to make a note of the serum tryptase level, make sure that a testing for D816 mutation has been performed, and in addition, before rendering the diagnosis of indolent systemic mastocytosis, make sure that we have taken into account that the patient has no C findings and patient does not meet the diagnosis of an advanced systemic mastocytosis. So now let's go over the diagnostic workup. So to make a diagnosis of SM, the WHO criteria needs to be fulfilled, which requires the major criteria and more than one minor criteria or more than 3 minor criteria. So the major criteria includes multifocal dense mast cell infiltrates, which accounts for more than 16 mast cells in aggregates that are detected in bone marrow sections or in sections of other extracutaneous organs. Under the minor criteria, it includes presence of an activating point mutation in the kit at codon 816 in either the bone marrow, blood, or another extracutaneous organ, or in bone marrow biopsy sections or biopsy sections from other extracutaneous organs where you see more than 25% of the mast cell infiltrates that have an abnormal atypical morphology. They are spindle-shaped, or in more than 25% of mast cells in a bone marrow aspirate, the mast cells look immature and have atypical features. In addition to the KIT mutation, the mast cells, they express aberrant markers like CD25 plus minus CD2, in addition to normal mast cell markers like mast cell tryptase and CD117. And the fourth minor criteria is an elevated serum total tryptase level, which is more than 20 nanograms per ml. So once a diagnosis of SM is thought about, the next step is to make sure whether the patient falls into non-advanced SM or the advanced SM. So in the non-advanced SM, you call it an ISM or an indolent systemic mastocytosis when the criteria of systemic mastocytosis is maintained. But then once the patient has more than 2 B findings denotes burden of disease, increased burden of disease, then we categorize these patients as a smoldering systemic mastocytosis or an SSM. So what are the B findings? B finding stands for increased, means more than 30% infiltration by mast cells, or the burden of disease is so much that the serum tryptase level is elevated to more than 200 nanograms per ml. There is signs of dysplasia or myeloproliferation in the non-mast cell lineage. And the third criteria is the patient has a hepatomegaly without impairment of liver function and or palpable splenomegaly without hypersplenism, or a lymphadenopathy on palpation or imaging studies. So that is the non-advanced SM, the smoldering systemic mastocytosis. Now, how about the advanced systemic mastocytosis? Under the advanced systemic mastocytosis, we have the aggressive systemic mastocytosis, the systemic mastocytosis with AHN, and the mast cell leukemia. So for a diagnosis of an aggressive systemic mastocytosis, the patient needs to have more than one C finding, and the C finding denotes bone marrow dysfunction, which is manifested by more than one cytopenias, palpable hepatomegaly with impairment of liver function, in that the LFT, the liver function test, is altered and the patient presents with ascites and or portal hypertension, palpable splenomegaly with hypersplenism, malabsorption due to GI involvement and the patient presents with weight loss, and or skeletal involvement by large osteolytic lesions and or pathologic factors. So if you have more than one of these C findings, we call it an aggressive systemic mastocytosis. For systemic mastocytosis with associated hematologic malignancy, this just means the patient has an SM and in addition has another hematologic neoplasm. And note that these hematologic neoplasms could be a myeloid disorder, could be a lymphoid disorder, or could even be a plasma cell process. And the third category is the mast cell leukemia, which is a very, very rare entity. And few points about mast cell leukemia is that in this entity, you see circulating immature mast cells, which are more than 10% of the peripheral circulation. A point to note that patients with mast cell leukemia, they do not usually have cutaneous manifestations. And in many of these patients, the diagnostic KIT D816V mutation is not present. However, these patients can present with other KIT mutations in the 816 codon. Therefore, when there is a suspicion of mast cell leukemia, it is important to do the entire genotyping of the KIT gene, because you do not want to miss the KIT mutation. So it is important, to nail the diagnosis of mastocytosis, right, and to make the accurate diagnosis, we need to identify the mast cells, and that is by using immunohistochemical markers, which includes CD117, which is positive in mast cells, mast cell tryptase, which is highly specific for mast cells. So both the CD117 and the mast cell tryptase will help us to quantify and characterize the mast cells within the bone marrow. Next, CD25 is performed because CD25 is an aberrant marker which will be expressed by neoplastic mast cells. Other markers that can be performed is a CD2, and CD2 expression is also an aberrancy, and it is expressed on neoplastic mast cells and not by normal reactive mast cells. But a point to note is that the CD2 will also stain T cells and NK cells. Therefore, it is important that when you evaluate the CD2 marker, you need to add additional T cell markers like a CD3 to make sure that we are not overcalling the CD2 positive cells as mast cells when indeed they were just T cells or NK cells. Some authors believe that a CD30 expression is also indicative of neoplastic mast cells. However, I have not been very successful with CD30 staining on neoplastic mast cells. And a very important point to note is that since the mast cells are CD117 positive, it is very important to perform a CD34 staining because we do not want to miss an associated increase in myeloids, myeloblasts, right? And we do not want to miss an associated acute myeloid leukemia. Therefore, always perform a CD34 when evaluating a case with systemic mastocytosis. A few words about the KIT mutation and the KIT receptor. The KIT receptor, it belongs to the tyrosine kinase 3 receptor family. And the proto-oncogene for the KIT receptor is the KIT gene, which is present on chromosome 4q12. And like I said, the KIT receptor is a tyrosine kinase type 3 receptor. So when the KIT receptor binds to the KIT ligand, which is a stem cell factor, there is constitutive activation of the KIT receptor, which leads to phosphorylation, and this leads to mast cell proliferation and differentiation. But note that when there is a KIT mutation, it leads to a ligand-independent autophosphorylation, leading to activation and uncontrolled mast cell proliferation, leading to neoplastic clonal proliferation of mast cells. So the KIT mutation that is positive in 95% of cases is present on exon 17, and it is the D816V mutation. Very rarely, you can also see the D816Y, 816F, so on and so forth. But just remember, 95% of systemic mastocytosis carries the D816V mutation present on exon 17. So how do you analyze the KIT mutation? So KIT mutation analysis, it is recommended that KIT mutation analysis be performed by using high sensitivity assays. According to the NCCN guidelines, myeloid mutational panels alone are not recommended for detection of KIT D816V mutation. This is because the standard NGS assays exhibits a low sensitivity and it can miss some of the KIT mutations, and therefore higher sensitivity assays should always be performed when there is a suspicion of a systemic mastocytosis. So what are these high sensitivity assays? These include the allele-specific oligonucleotide qPCR or the ASO qPCR, or the digital droplet PCR, the ddPCR. It is recommended that in a patient that you suspect systemic mastocytosis, it is recommended to perform a high sensitivity peripheral blood KIT mutational analysis just to screen the patient and then follow it up by other studies. So a very important note here is that finding incidental KIT mutations on a myeloid NGS panel should always trigger a full diagnostic workup for advanced systemic mastocytosis. This is because we know that in patients with advanced systemic mastocytosis, 70% of these patients have an associated hematologic neoplasm. Therefore, when we perform a NGS panel and the KIT mutation is positive when there is a myeloid malignancy, it is very important to go back and check and see if we are missing an additional systemic mastocytosis. Therefore, a thorough workup is required for definite diagnosis of systemic mastocytosis. And how do we do this, right? So if there is any adult who presents with symptoms, that are concerning for mastocytosis, symptoms of mast cell activation, recurrent unexplained anaphylaxis, mastocytosis affecting the skin, elevated serum tryptase levels along with unexplained osteoporosis, especially in a male, unexplained hypotensive syncope, splenomegaly, lymphadenopathy, or other CBC abnormalities. The first test to do is not a bad idea. Do a screening test, do a high sensitivity assay on the peripheral blood to detect the KIT D816V mutation. Additional studies should be performed to evaluate for systemic mastocytosis, and that includes a thorough medical history, physical examination, evaluate the skin, get a serum tryptase level, bone marrow biopsy or biopsy of the other organs that are suspected to be involved, evaluate the KIT D816V mutation with a high sensitivity molecular assay, and make sure to rule out a FIPL1 PDGFR alpha mutation, translocation if the patient presents with eosinophilia. So now we talked about, how to make a diagnosis of SM. Now let's talk about what are some of the technical challenges in making this diagnosis and how can we optimize testing in the lab. So what are some of the barriers that interfere with the diagnosis of patients, and what can we do as pathologists, right? The first barrier is appropriate testing is not ordered by the treating physicians. For example, the treating physician does not order the KIT D816V mutation, and in that way, these patients can be missed. Number two, the C findings can be difficult to assess. So this is a very important point because this will often happen when we get cases in consultation as a hematopathologist or a dermatopathologist. When we get cases in consultation, if there is no thorough history regarding the patient's, other clinical signs and symptoms, one may not be able to pick up the C findings, and therefore we may not be able to subclassify the systemic mastocytosis as an advanced systemic mastocytosis. In addition, it depends on the lab, right? If the labs, they do not have a good integrated process where the CBC data, the other lab findings are not integrated with the pathology findings, again, that lack of integration may actually be a problem because we can miss appropriate subtyping of mastocytosis as well as making a diagnosis of systemic mastocytosis. Something else that is important is technical challenges within the lab, right? Performing the CD117 staining tryptase staining, CD2, CD25 staining. There is lab-to-lab variability, and that is something that the pathologist can work on. And last but not the least, right, low level of KIT D816V mutations. They cannot be detected by the current NGS assays, right? So therefore, when there is a high index of suspicion, it is important to go on and order the high sensitivity KIT D816V mutation that are now currently available in some of the commercial labs. What else? So, like we said, the mast cells, they can sometimes be tricky in systemic mastocytosis. Okay, there can be mast cells that can look like, sometimes in neoplastic mast cells, the granularity may be decreased, and they may not be very obvious on H&E stain slides, and therefore the diagnosis of, or even detecting the mast cells may be difficult. On a bone marrow section, or even in other extracutaneous organs, the mast cell involvement may be in aggregates and can be patchy. Sometimes the mast cells can be spindle cells. They can be elongated. They can look immature or bilobed. Especially when they are elongated and spindles, these mast cells can be confused with fibroblasts or like fibrosis, right, histiocytes, so on. And another point is sometimes the mast cells, they can be in aggregates in perivascular locations, paratrabecular locations, which can again be missed if there is no good biopsy, right? If the biopsy is fragmented and small. Therefore, it is recommended that in a bone marrow biopsy, to make a good diagnosis of mastocytosis, make sure that we have a good bone marrow biopsy, and by a good bone marrow biopsy, and therefore, again, because of this patchy involvement many a times, right, the quantitation of the mast cells may be difficult, and identification of these mast cells may be difficult. So this is a very interesting study that was published in the Journal of Modern Pathology. And it was shown that systemic mastocytosis may be missed in patients with suspected myeloid neoplasm. This was a retrospective review of 64 patients with suspected or confirmed myeloid malignancies who also had an underlying KIT mutation. Of these patients, it was shown that there was a concomitant undiagnosed systemic mastocytosis in 22 patients who had an associated chronic myeloid neoplasm. So the chronic myeloid neoplasms were CMML, MDS-MPN unclassified MDS or an MDS or an MPN, and of these 22 patients, it was shown that all these patients were positive for KIT mutation, but the 20 of the 22 of these 22 patients, or 91% of these patients, they had an underlying systemic mastocytosis in association with the chronic myeloid neoplasm, which was missed. In addition, it was shown that in 35% of these confirmed cases, there was no clinical or pathologic suspicion of an underlying systemic mast cell disorder, and a diagnosis of SM-AHN was not rendered on initial pathologic review. So the bottom line here is that, especially when evaluating for chronic myeloid neoplasms, if there is an associated KIT mutation, it is very important to check and double check that one is not missing an associated systemic mastocytosis. And in the same population, it was found that in 7 of the 9 cases, the mast cell infiltrate was not observed on initial H&E sections and was later revealed only when IHC was done during further workup. And in 2 of the 9 cases, the mast cell infiltrate was not even seen on the initial H&E sections, and deeper tissue sections needed to be analyzed to make a diagnosis of increased mast cells. Therefore, this again brings home the point that, in order to make a diagnosis of SN, make sure that the immunohistochemical stains are appropriately performed and they are reviewed. And number 2, if you can't see the cells, it's not a bad idea to get deeper sections to evaluate and to exclude or include the diagnosis of SN. Additional markers, like I said before, may be considered for diagnostic workup. And a few points about CD117. CD117 is a highly sensitive stain to detect mast cells, but it is not specific. And like I said, it is not only present on mast cells, but it can also be found on germ cells, melanocytes, hematopoietic stem cells, and the interstitial cells of Cajal. So that's something that we need to keep in mind. And therefore, especially on bone marrow biopsies, the CD11 staining should always be done in unison with a CD34 staining. Number two, the CD2 expression on mast cells can be challenging to interpret because we know that CD2 can also be expressed on T lymphocytes and NK cells. And therefore, it may be sometimes difficult to differentiate whether these are the lymphocytes or the mast cells. Therefore, it is important to do additional T cell, NK cell markers like a CD3. Tryptase staining is a highly specific stain for mast cell, but its expression is quite variable. And many a times, like I said, the neoplastic cells may lose their granularity, as a result of which the tryptase staining may be suboptimal. And lastly, 1 to 5% of patients with systemic mastocytosis actually may not have an elevated tryptase level, and therefore that can be missed. So how about the cytologic features of mast cells? It's not that easy. It can be challenging. So the first diagram here shows a well-differentiated reactive mast cells. So you can see these are small to medium-shaped cells. They have a central nucleolus, condensed chromatin, and the cytoplasm looks well granulated. Then the neoplastic mast cells that are seen in systemic mastocytosis or in mast cell leukemias, right? They can be elongated. Or many a times the nucleus can be immature. They can be bilobed, and the granularity can be quite variable. Sometimes, especially in mast cell leukemia, the mast cells, they can have very high nuclear to cytoplasmic ratio, fewer metachromatic granules in the cytoplasm, and they can have prominent nucleolus. Therefore, the cytologic features of mast cells can be highly variable. So that's something that we need to keep in mind when evaluating mast cells. Some of the cellular markers that can help to make the diagnosis of neoplastic mast cells, like I said, in systemic mastocytosis, the mast cells, they will be dense aggregates of mast cells, and the phenotype is CD25 positive, plus minus CD2 positive, tryptase positive, CD117 positive. Well-differentiated systemic mastocytosis, well, it's again tryptase positive, CD30 positive. This is a very rare entity. Acute basophilic leukemia, again, very, very rare. But note, in acute basophilic leukemia, the KIT D816V mutation is negative. And in addition to the tryptase positivity, these cells can also co-express CD13, CD33, CD123 is positive. How about mast cell hyperplasia, non-neoplastic, just pure mast cell hyperplasia? Note that these patients, the mast cells will be tryptase positive, CD11 positive, but they will not co-express CD25 and CD2. And in addition, the KIT mutation will be negative. And then you have the myelomastocytic leukemia, tryptase positive AMLs, which are all very rare, and then they are negative for the KIT mutation. So again, going back to the tryptase staining, we have to be very careful because this is a case of a systemic mastocytosis with associated MDS, MPN, unclassified. And you can see that the mast cells are very clearly demarcated by the CD117 staining. You can see sheets of mast cells. However, the tryptase does not do justice to this case because it's kind of weak staining. Okay, so therefore it is important, right? In addition to tryptase, we have to do additional markers just to make sure that we don't miss the mast cell burden. So identification of KIT mutation is a key step in the diagnosis of systemic mastocytosis. And like I said, we need to use high sensitivity assays if needed to pick up the KIT mutation. But a point to note is that it is also important to recognize the co-mutations in these cases because it has been shown that co-mutations in SRSF2, ASXL1, and or RUNX1 in patients with systemic mastocytosis are associated with reduced overall survival. So this is a lab-based assay. So this is a graph that shows comparison between next-gen sequencing and digital droplet PCR, or the high-sensitivity PCR. This is a testing that was performed on 39 patients that were diagnosed with indolent systemic mastocytosis. And here you can see that the digital droplet PCR, or the high-sensitivity PCR, the KIT mutation was detected in 95% of patients on the peripheral blood samples, when compared to the NGS assay that picked up only 28% of these patients. And in addition, if you look at this graph here, you see that the mutant allele frequency, the digital droplet PCR, was 30-fold greater in terms of sensitivity over NGS for measuring the mutant allele frequency, and the median percentage of the MAF ranged from 0.2 to 30.22 by digital droplet PCR when compared to NGS, which ranged from 1.9 to 32. So this clearly shows that the digital droplet, or the high sensitivity PCR, is highly, highly sensitive, and the lower, for detection, the lower limit of detection for the ddPCR is far lower, right? 30-fold greater sensitive when compared to the NGS assay. In addition, the ddPCR has a greater diagnostic sensitivity when compared with serum tryptase level, 77%, and presence of bone marrow mass aggregates, 90% more sensitive, ddPCR. So here, this is a table that shows the different testing modalities to analyze the KIT D816V mutation on peripheral blood or bone marrow. So, one can assess the KIT mutation by doing a Sanger sequencing, next-gen sequencing, RT-PCR followed by HPLC. This is purified nucleic acid-mediated PCR, allele-specific oligonucleotide qPCR, and the ddPCR, and you can see the advantage and the disadvantage. And the third row shows us the sensitivity. And here for the Sanger sequencing, the sensitivity is 10 to 20% when compared to 5% for NGS. And the sensitivity, it increases to 0.01% when you do highly specific ASO qPCR and the ddPCR, so highly sensitive. So the bottom line here is that the Sanger sequencing and the NGS and the next-gen sequencing are not recommended due to low level of the KIT D816V detection rates. These are some of the advantages, disadvantages of the different testing modalities. And these are some of the commercial labs that provide either the ddPCR or the allele-specific PCR. So, when in need, these testing modalities are available in some of these commercial labs. So, in conclusion, making a diagnosis of systemic mastocytosis, one needs to use appropriate immunohistochemical markers to accurately detect neoplastic mast cells and quantitate the burden of involvement. We have to perform high sensitivity KIT mutational analysis on all appropriate patients with suspected systemic mastocytosis. Many a times, accurate diagnosis may require additional immunohistochemical staining and deeper sections. And a point to note here is that the type of tissue and the biopsy material is very, very important. We need to have a good biopsy specimen, good representation to make the diagnosis. And it is important to have good lab data, a thorough evaluation of the patient's CBC, lab values, and it is a job of the pathologist to render a clear-cut, concise, and integrated report, taking into account all the different parameters to come up with the right diagnosis of systemic mastocytosis and subclassify these patients as non-advanced systemic mastocytosis or advanced systemic mastocytosis based on all the data that is available. With that, I think I'm done with my presentation. Thank you all once again for your attention,